Hi, Dr. Garima here again, and we'll be discussing one more of the scenario-based questions for the Australian Dental Council exam. By now, you must be aware of what I do when I shoot a video, so I'll not take much of a time and we'll directly start with it. Uh, Today's question is a very important question. Actually, all of the questions are very important, but for sure, when I say important question, it's not only from the exam point related, but it's clinical point related as well. Like such questions, scenarios you will daily face in your clinical practice, like literally daily. So pulp is a structure which is responsible for giving pain when it is disrespected by caries or some other thing, and when it screams in pain, the patient comes to you, especially the Asian population, where 6 monthly regular checkups is generally not in our upbringing. We usually go to the dentist only when there is a problem, correct? But the other developed Western nations, the crowd that I see, of course, it also depends on individual family to family, but in general, uh, the quality of dental care, the way people maintain in Western countries is obviously very nice because even if they don't have anything, they'll come for a regular dental checkup, citing that it's their 6 monthly checkup due, which is very good because often if a patient is attending to you regularly, chances of having something major is reduced. So dentistry itself doesn't become a painful experience as you're doing cleaning, scaling, probably a filling here and there. But if a patient tends to come to you only when there is a problem, usually it's not just one tooth, multiple teeth are involved, and sometimes they come at a very badly advanced stage where you have no other option but to either do a root canal or extract a tooth and do further procedures, which not only increases the cost but also local anesthesia gets involved and longer durations of the procedures are involved, and the patient further gets scared saying this is what happens when I come to a dentist, so I try to avoid unless I really am in pain, and that vicious cycle always continues with dentistry becoming a very traumatic experience and an experience to be avoided. So that should not be the case, but unfortunately that is the case. So if you are one of those people who visit the dentist only when there is a problem, try and change your attitude. But anyways, let's just go for this question. A 30-year-old patient complains of severe attacks of pain. Okay. Each of a few seconds duration and fading slowly, but she cannot identify which tooth is responsible. A lot of keywords out here. Any pulpal diagnosis question, a lot of keywords and a lot of close-ended questions should be asked in order to arrive to a proper diagnosis, because you have to make sure whether you want to touch the pulp or not, because once you touch the pulp everything is irreversible. Like you cannot go back to a healthy state of the pulp once you are touching the pulp. So you should first decide whether you want to touch the pulp or you don't want to touch the pulp, and for that you have to ask very specific questions in order to understand the symptoms and how the tooth is behaving. So, severe attacks of pain, but of few seconds duration. Okay, but cannot identify which tooth is responsible. Hot, cold, or sweet foods and cold air on the upper right jaw makes the pain worse. So, there are specific triggering factors. The patient attends on a casual basis for dental treatment to you, despite of the fact that the scariest lesion is very large, perhaps surprisingly. It is the only lesion in an otherwise intact arch, and there have been no other lesions noted in the last 3 years. The patient is therefore classified as having a low risk for dental caries. Okay, low risk for dental caries pretty much means the patient is good on hygiene and diet measures, but still happens to have this one tooth which has such a huge cavity. Now, see, if I want to diagnose the status of the pulp, what am I going to look at? Pain history. Severe attacks of pain. Okay, the pain is intense, but Now I have to differentiate between reversible pulpitis and irreversible pulpitis because classifying the diagnosis is going to determine my treatment plan. Like for example, if I classify this as irreversible pulpitis, if I think I'm sure of it, then definitely I'll have to open up the pulp. But if I classify this as a reversible pulpitis, then I'll try to salvage the pulp by either doing IPC or something else, you know. So I really need to know so that I do the right kind of treatment and the patient doesn't have pain. Also, if it is indeed irreversible pulpitis, then I cannot do IPC because I'll end up aggravating the pain of the patient, eventually leading to an abscess and severe night pain. So I really, really need to be sure of it. So how will I be sure of it? So I'll again go back and check the pain history. Now, pain history is a few seconds and it's triggered on a response, which is taking me more towards reversible pulpitis. If it was irreversible pulpitis, then I would be having lingering pain and spontaneous pain without any stimulus. Understand? Because here the question has specifically mentioned certain stimuli and pain of few seconds only, there is a high chance this is reversible pulpitis. But of course, when you see a deep lesions, now I'm talking to you from the clinical point of view, I will always tell my patient that it seems that your nerve is not infected completely, but it is involved to a certain extent. But there is a 50-50 chance it's going to stay that way if we try and protect it right now. It may also happen that once I'm done with my treatment, which is like covering the nerve with some obtundant or sedative dressing and then putting a filling over it, in the next 6 months or 1 year or so, it still may end up getting infected and going for a root canal because whenever the carious lesion is deep, even if you try to salvage it, sometimes microscopically the bacteria have entered the pulp and the pulp is not able to defend itself, and then it can go for an irreversible pulpitis. You never ever promise the patient of a reversible pulpitis that the tooth is going to stay healthy the way it is forever once you're done with the treatment. Always remember that. So once the patient understands this point, they'll be mentally prepared if indeed the tooth goes for a root canal later and won't blame you that the doctor had done the treatment, but then still why it's giving me a problem. You understand? So reversible pulpitis cases, always you have to inform the patient that in future RCT may not be needed. So anyways, coming back to this question, let's see what are the sub questions. A reversible pulpitis diagnosis is supported with intermittent repeated attacks of pain, pain on biting, tenderness over roots. No, that means a periapical infection is there. Continuous severe pain is irreversible pulpitis and none. We already discussed it's intermittent repeated attacks of pain. Intermittent, not lingering. What will you do first? Remove the stimulus and insulate the inflamed pulp. DPC and insulate the inflamed pulp. Commence root canal treatment, prescribe analgesics, extract the tooth. Extraction is not a wrong option, but it's an extreme option. So unless the patient really wants it, you're not going to jump onto that. Prescribe analgesics can be done, but it's not going to help the tooth. It will just help temporarily relieve the pain symptoms, and that is not for sure long-term treatment. So no. Commence root canal treatment. It's not irreversible pulpitis. You don't have to. DPC and insulating the inflamed glands. See, direct pulp capping, the whole point of reversible pulpitis treatment is to protect the pulp. So I will not jump to DPC unless I have put a rubber dam, I'm excavating the caries, and accidental pulp is exposed. But again, DPC won't be done in a carious exposure of the pulp. It is always a mechanical exposure of the pulp. So even if I've put a rubber dam and I'm excavating the caries and it's deep caries and a pulp is exposed, I will not do DPC. I'll go ahead and I do a Civex pulpotomy instead. Remember this point. A DPC will always be done only in a mechanical exposure of the pulp under rubber dam, not carious exposure of pulp under rubber dam. Remove the stimulus and insulating the inflamed pulp. Yes, remove the stimulus in this scenario is caries. So I'm going to remove the infected dentine. I will let the affected dentine be there And the best way to do is to use a spoon excavator, because with the burrs, you'll not get that feel which you will get with the spoon excavator. And you will put an insulating sedative dressing over the affected dentine. You should know by now what is infected dentine and affected dentine, and you will explain the same to the patient as well. And there are questions in ADC over infected and affected dentin, so read that also, the histological sections of it. And then I'm just going to fill it up and ask the patient to follow up with me every 3 months or 6 months, or if there is a sharp shooting, severe pain attack at night, or an abscess develops, then contact me immediately. Now, what is the best method to remove carious dentine to fulfill the concept of minimally invasive operative treatment? MID, minimally invasive dentistry. I had a seminar over that when I was in my first year of PG, I remember, and I had made a nice presentation which even had the concept of ozone layer cleaning the dentine. I don't even remember what that was now. But yeah, I had prepared something like that. But anyways, so the best method to remove the caries, best method, best is the key word, because whenever a question is mentioning this keyword, that means all the options given would be correct. Now you have to choose the best method. It's like you're going to shop and you're choosing the best dress, but all the dresses you like, you want the best dress to choose. So, anyways, photoactive disinfection. Okay, lasers. You know the full form of laser, right? Light amplified stimulated emission of radiation. Yes, I know it. Ozone technology. See, I just spoke about it without even seeing the options. Hand excavators and carbon steel burrs. As may fancy the ozone technology may sound, I'm sure a lot of clinics in general don't have it, don't know how to use it, and don't know which are the cases to use for it. Carbon steel burrs are a good option, but again, it's a burr, and there is nothing better than having a tactile sensation with a spoon excavator. So I'm going to go with that technology, which has been existing since the start of dentistry. Your hand and a spoon, and you excavate. So that is the best option of choice. A lot of times when I take spoon excavators and my children patients ask me, Doctor, what are you doing? I'm like, see, this is a small spoon. It's like your ice cream scoop. How you scoop an ice cream? I'm going to remove the caries out of your tooth. And they start laughing and they're like, okay, doctor, go ahead. So, yeah. Now, immediate definitive restoration is the best course of action because. So, immediate, that means on this chair when you have examined. Definitive restoration meaning a restoration that is going to last for some time, not like a temporary restoration. And that should be done on this tooth because you have seen the tooth, right? It's a huge carious lesion. And if you just put a temporary one without removing full caries, then there is a weakened tooth structure and it's bound to fracture. And when you're going to remove caries, it will still become a weakened tooth structure bound to fracture. So you have to give some dental filling material which is strong enough to resist the compressive strength of biting, right? So, what is the immediate definitive restoration for the best course of action? Best again. That means again all the options would be correct and I have to choose the best one. Composite resin as a restorative require crown coverage. Okay. Removal of caries will leave a weakened crown. That's true. When the patient requested for better aesthetic results, none of the above. So the question is asking, I should be giving a restorative material because. So composite resin as a restorative requires crown coverage. I can give composite resin. I can also put GIC. I can also put silver amalgam. All three are good. But the option A is saying that if I give composite resin, I also have to give a crown coverage. Immediately crown coverage is not required for this tooth. And I have to give a definitive restoration because why? Because when I'll remove the caries, it will leave a weakened crown. That is my logical reasoning of giving a definitive restoration. Even if suppose I choose that my definitive restoration is a crown, and you must have seen in a lot of patients, crowns are placed, and when you take X-ray and the patient is like it was placed 10 years ago, doctor, and you see but the root canal is not done inside it, and they'll be like, yeah, but the doctor said there was a huge cavity and that's why they placed a crown. Makes sense. So they had placed a crown because either the filling would not have stayed or the tooth structure was so weak that it would have fractured if only a filling was placed. And that's why a crown was given. So the main logical reasoning is you have the removal of caries will leave a weakened crown. If this option was not given, then I would have gone with option A. So since the question is saying that the best course of action is to give a definitive restoration because the tooth will become weak when I remove caries. So the option B is the right answer. Uh, it is not when the patient requests it. So I hope you have understood what I'm trying to explain here. As such, it looks like an easy question, but because there are keywords like best, initial, first, all the options are right, so you really have to think hard what is the right answer. And it is such questions that consume a lot of your time in exam. And it is such questions that are always marked because when they have said best, it has only one option, not two options. So they cannot be unmarked. So you should try and ace yourself solving such questions in limited amount of time, and that can only be done with repeated practice. We currently have 27 mocks. Practice as many times as possible to condition your mind. This is exactly how your paper will come in the exact same format. So I hope this is clear, and I'll leave the rest of the details of where you will find the books and how to, and you'll get a trailer of the exam as I'm providing a link of a sample mock in the description below. So leave a comment as to how you liked it, and best of luck for the exam. Bye bye.